This is a recording of my presentation during the past 2026 meeting, ticketed event on Friday morning, Neonatal Resuscitation 2026 Beyond the Basics. I would like to thank Praveen and Satyan for inviting me to speak today on could sustained inflation and vasopressin be an alternative pathway to resuscitate neonates. I certainly would like to discuss and disclose that the chest compression technique I will discuss was invented by myself, and I will discuss off-label use of vasopressin. Chest compression at birth are an extreme rare event, and from the 140 million babies who are born every year around the world, around 2 to 3 million will require chest compression. It's only around 0.1% in term babies and up to 15% in preterm babies. Despite our best effort of providing chest compression or vasopressors, around 1 million newborn babies still die. And if they survive, there is a high rate of short-term sequelae as well as longer-term disabilities. It is important to notice that survival decreases with every minute of chest compression. And if you provide 10 minutes of chest compression and have no signs of life, your mortality is further increasing, and in survivors, the rate of moderate to severe disability is extremely high. This poor prognosis associated with receiving chest compression alone or with medication always raises the question, is there anything we can do to improve the current approach and improve outcomes? It is infrequently used, and that certainly has limited our ability to perform rigorous clinical studies. Now, the 2025 neonatal resuscitation guidelines from the American Academy of Pediatrics and the American Heart Association shows that it might be reasonable to deliver 3 compressions followed by 1 ventilation breath in a 3-to-1 ratio as the current approach of providing chest compression. And I will mainly focus on this approach. We know from many studies that high quality chest compression is extremely important, and it's a cornerstone to achieve ROSC. So we need to press hard and fast, ideally with minimal interruption, to achieve faster ROSC. Now, when we have asphyxia, which is the main cause in newborns, then we need to add ventilation, because that has been shown, in particular in animal studies, that it further improves neurological outcomes at 24 hours compared to just providing chest compression. So this highlights the importance of chest compression. Now, highlights the importance of ventilation. Now, a caveat of ventilation is lung de-recruitment, which has been overlooked for many, many years. And this nice study from some anesthetists, where they gently pressed onto the chest and then released the chest. They didn't not forcefully push the chest down like you would do during chest compression. They gently push down and then release the chest to assess how much volume is actually moved in and out of the lung. And they did that with face mask or after intubation with a cuff tube, and assessed the volume going in. And I will zoom in the first months, so our newborn babies. And what you can see is that the big black line is the dead space, which was calculated based on body weight. And you can see that in some cases it's above the dead space, and in some cases it's below the dead space. And this was, as a reminder, with a gentle push onto the chest. Now imagine you're providing chest compression. And here is the 3:1 compression to ventilation ratio, which I assume everyone here has potentially done to newborn infants, at least in simulation, where you do 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. And what you can see is here, with each inflation, you get volume in, and then you have 3 chest compression where the air is pushed out of the lung. If you analyze this area under the curve, you see that there is a tidal volume loss of up to 4.1 milliliter per each 1 and 2 and 3 and breathe cycle. So this means that the lung is continuously de-recruiting. And this might be a reason why previous animal studies where they compared different compression to ventilation ratios were unsuccessful because of this loss. Now, there have been several studies who examined that. They examined this in adult and found that if you do compression-only chest compression, which is the current recommendation in adults, your lung atelectasis, which is in this case 25% prior to starting chest compression, increases to 75% within 7 minutes of chest compression. So extreme de-recruitment of the lung. Already showed you what it happens in neonatal piglets, but if you, instead of using 3:1, use the pulse approach of continuous ventilation with asynchronized ventilation, you also get the lung de-recruitment. So you're collapsing the lung. Now, as we said, we lose volume when we provide chest compression. And what you all know is that lung recruitment, creation of FRC, so functional residual capacity, is one of the most important steps in neonatal resuscitation so that you aerate the lung. Now, when we start chest compression, we actually reverse it. We de-recruit the lung. Now, I showed you 3:1. We used a different approach. What we did is we provided continuous distending pressure of around 30 centimeters of water. It's like a sustained inflation, and that's what we called it. So you just occlude the T-piece and provide this high PEEP or PIP at 30 and provide continuous compression. As you provide continuous compression, and I will go into this in more detail in a little bit, you can see that as with 3:1, air comes out of the chest, but the moment you release the chest, air goes back into the lung, and that way you do not de-recruit the lung. Now, the first study we ever did in our piglet model showed roughly a 75% reduction in time to ROSC compared to using 3:1 and a significant improvement of survival. What was the difference? Well, one of the differences was that we were able to recruit the lung and gain tidal volume because of passive ventilation, because during each chest recall, this high distending pressure pushed air back into the lung. So compared to 3:1, where we have de-recruitment, we have actually lung recruitment. In addition, how does the blood actually flow during chest compression? Well, there are two formulas postulated. One is the cardiac pump theory, where you squeeze the heart like a sponge between the sternum and the spine, and this is how the blood is ejected. The other theory is the thorax pump theory, where with each chest compression, you increase the interthoracic pressure, and this makes the blood flow. Now, every interruption will stop the blood flow and has to be rebuilt. Now, imagine when you do 3, you get maybe a little bit of blood flow and then it stops again. compared to continuous chest compression, where it is continuously to increase. Now, we recently published a study where we did ultrasound to assess what the heart actually is, and in term newborn infants, you can see when you provide chest compression where it is recommended according to the neonatal resuscitation guideline, you potentially squeeze the right atrium or the right ventricle, but never the left ventricle to get cardiac output. So this maybe is not the most important theory for how the blood flows, at least in newborns. So cardiac pump theory maybe contributes, but it's not the main factor. In comparison, the thorax pump theory, where you increase the interthoracic pressure, as you can see here, with CC+SI compared to 3:1 or PALS, you always get a significant increase in interthoracic pressure and a significant increase in, if you look at the graphs to the right in A, pulmonary artery blood flow during chest compression, as well as carotid artery blood flow during chest compression. You also get a significant higher pulmonary artery pressure, mean arterial pressure, and there's a lot of concerns over that this sustained inflation will impair venous return, but as you can see here on the CVP, this is not different between the two groups. Now, after several animal studies where, in summary, we found that CC+SI is 75% faster to achieve time to ROSC. We were able to halve mortality. We had twice as high pulmonary artery blood pressure, twice as high pulmonary artery pressure. We had higher carotid blood flow. We had no difference in venous return. We had 3 times higher minute ventilation and thereby improved alveolar oxygen delivery. We are able to achieve passive ventilation, lung recruitment, and had no lung or brain injury when we examined injury marker, which you can see on the bottom right. And we had 0 pneumothoraces. This is another concern, that because of the lung recruitment and the sustained inflation, you might get pneumothoraces. We also identified that you need at least a pressure of 25, the standing pressure or peak inflation pressure, to deliver 5 mils per kilo of tidal volume. And after all these animal studies, we started to translate this into human trials. We started off with our SURVIVE journey, where we compared 3:1 with CC+SI. The first was a feasibility study where we randomized our patient individually. They were all less than 32 weeks of gestation, and many of them were like 24 to 26 weeks gestation. Despite their extreme prematurity, the time to ROSC, as you can see, was significantly reduced, again by around 75%, compared to using 3:1, and the 75% is basically similar to what we found in our animal studies. We had 2 deaths, but as I said, these infants were like 24 to 25 weeks gestation and died of sepsis and necrotizing enterocolitis, so not necessarily related to the chest compression. And in the bottom left, you can see that, again, what I showed you before in piglets, doing 3:1, you de-recruit the lung, and doing CC+SI, you get lung recruitment. And I would like you not to share this on social media because this is unpublished and we are in the current process of publishing it. So, in summary, 3:1 in piglet models as well as in newborns, you de-recruit the lung, while with CC+SI, you recruit the lung. This brings us to our SURVIVE trial we completed prior in the COVID pandemic and then stopped during the COVID pandemic, where we tried to see if using CC+SI compared to 3:1 will reduce the time to ROSC. which was defined as having a heart rate above 60 for at least 60 seconds after you stop chest compression. Our sample size calculation indicated that we would need 218 infants, 104 in each group, to get a 33% reduction in time to ROSC. We included all preterm and term infants, and we randomized the hospitals in a cluster crossover trial to up to 12 months for CC+SI versus 3:1. We started in 2017, and then the SAIL trial, which you might all are familiar with, which was a sustained inflation versus intermittent positive pressure ventilation in 23 to 26 weeks gestation infant as the initial respiratory support, and that trial reported a higher mortality with sustained inflation. So we stopped our trial, and then with discussions with the steering committee, the DSMB, and the parents and representative and ethics committee, we agreed to do 28 plus 0 or older and term infants and restarted the trial. We had several ethics boards who wanted to wait until the first interim analysis. We also struggled initially to get insurance for the trial. For anybody who doesn't know, if you do a trial hypothetically in several countries, you need insurance for the patients, because those things are generally covered within your own country, but not in other countries. And it took us 3 years to actually find an insurer to insure this. And despite our best efforts, where we were all ready to start, COVID came around, which shut down a lot of our research. And then we stopped the trial extremely early and did not achieve what we were aimed to achieve. We were able to get 11 infants with CC+SI and 14 infants with 3:1. Here you see the demographics of the two groups. Now, the time to ROSC was 90 seconds for CC+SI and 615 seconds, or over 10 minutes, with 3:1. And this 10 minutes is roughly the time which is reported in registry. Now, as this was a cluster trial, the analysis is slightly different. So the p-value which is important is your p-value of p0.16. Similar with mortality and survival. The survival was higher with CC+SI, but this was not statistically significant. Now, from a safety perspective, we showed that there was no higher rate of pneumothoraces, there was no higher rate of intraventricular hemorrhage or periventricular leukomalacia. So in conclusion, the SURVIVE trial showed no difference in time to ROSC, no difference in survival, no difference in any secondary outcomes or delivery outcomes, and no safety concerns. A meta-analysis from us from both trials showed that there is a up to 2-minute reduction to time to ROSC. And if you remember from earlier, every minute of chest compression increases mortality by 9%. A 2-minute reduction would mean a reduction in mortality by 18% on average. And there was no difference in mortality because one trial had a higher mortality, 205 versus 0.4, and then the next trial had a lower mortality. But this gave us enough power and data and evidence to move on to the next trial, the SURVIVE-2 trial. Here on the left you see the steering committee, and on the right you see the DSMB, which is led by Vali Carlo, and members are also Myra Wyckoff and Stefan Bayang. Primary outcome of SURVIVE is mortality to hospital discharge, the first hospital discharge, and the sample size we calculated is 556 infants, or 276 per group, to detect a 20% reduction in mortality. We once again will include preterm infants, 28 weeks or older, and term infants who require chest compression in the delivery room. Each site will be randomized again as a cluster, which means they will change their hospital policy to use CC+SI or 3-to-1 for up to 24 months. The trial will be conducted in many countries around the world, including Canada, the United States, several countries in Europe, Zimbabwe, Australia, India, Pakistan, and New Zealand. If anybody is interested from their side to potentially join this trial, please come and talk to me after this session or join us on Sunday, April 26th, between 6 and 7 o'clock in the Omni Boston Hotel at Seaport for an investigator meeting. The next I want to talk about in the last few minutes is about epinephrine, because it's currently the only recommended drug for neonatal resuscitation. However, the evidence to use it is extremely limited. It's preferable giving IV. It can be given endotracheal to bridge until we have vascular access. The caveat with endotracheal is that, as Satya group has shown, that it is diluted in the fluid-filled lung and the absorption is delayed, and therefore it's not working as effective as we would like. Epinephrine, as already said, you should be giving it in a dose of 0.01 to 0.03 milligrams per kilo, preferable IV. The NRP simplified it by saying you should give 0.02 milligram per kilo, at least for the first dose, which then can be scaled up to 0.03 if needed. You give it every 3 to 5 minutes, followed by a flush of 3 ml of normal saline. This is all based on animal data or data from adults or pediatric, but not on neonatal data. Epinephrine, as you know, has several functions. It's vasoconstrictive via the alpha-1 receptors. It also has coronary vasoconstrictions via alpha-2 receptors. The beta-1 receptors increase your heart rate, your conduction velocity, your contractility, and your rate of myocardial relaxation. And it also relaxes smooth muscles and increases the contractility in the myocardium via the beta-2 receptors. However, it increases myocardial oxygen demand, as well as respiratory and metabolic acidosis. It also aggravates hypertension and tachycardia after ROSC. As I said, the evidence is mainly from animal or adults or pediatric data, because the human data, as you can see, and this is an ILCOR review from several years ago, is rather sparse. There are several case series or cohort studies published where they were using the epinephrine, but they were not randomizing patients to any of its use. An alternative we have investigated over the last several years is vasopressin. Vasopressin, as you might know, is an antidiuretic hormone. We all have. It's vasoactive via V1 receptor. It causes systematic vasoconstriction, but pulmonary vasodilatation, which, if you remember physiology, you have vasoconstriction of the pulmonary artery prior birth, and they need to relax after birth. So vasopressin can support this vasodilatation. It doesn't affect acidosis, regardless if it's respiratory or metabolic, and does not increase myocardial oxygen demand. There have been several randomized trials in adults, but these are like 20-25 years ago, when they analyzed subgroups. If the patient had a systole in by asphyxia, they found that giving vasopressin compared to epinephrine improved ROSC, as well as hospital discharge and hospital admission. So maybe because asphyxia and hypoxia is our main reason for cardiac arrest, so maybe it works in newborns as well. There's a little bit of data in pediatric patients, but this is also something where it's more given as a rescue. When you have given several doses of epinephrine and it's not working, then it is given, and often they survive better. And if it's given intentionally as the drug of choice, they also have better time to ROSC as well as better survival. Now, Satya and Praveen have done a study on using vasopressin in their ovine model where it didn't seem to work and did not show any difference in time to ROSC, but you can see that the pulmonary blood flow was higher, significantly higher. So certainly it works how we think it should work, and relaxing the pulmonary artery. We did our first study several years ago in our piglet model, and we found similar. We didn't find a difference in time to ROSC. Ours was relatively short compared to Satya and Praveen's study. But what we found is that 4 hours, up to 4 hours after ROSC, we had significantly higher survival. So the piglets were much more stable in the 4 hours we observed them afterwards. And here you can see that in a Kaplan-Meier graph, the survival for the 4 hours. And since then, we have done several other studies to assess different doses, to assess pharmacodynamic, pharmacokinetic of this vasopressin, as well as looking into injury marker. And what we found is that it improves cardiac blood flow as well. It has some benefits on brain injury. So if you look at interleukins and TNF-alpha, I picked one. There are reduction in the injury markers for 4 hours after a ROSC. So potentially also protects the brain slightly. Similar then with epinephrine, but I would think even worse because it's even less absorbed in the pulmonary if you give it endotracheal, because it's a peptide. So this might not be the optimal route for vasopressin. And one complication you notice when you give vasopressin over several days is hyponatremia, but just giving 1 or 2 or 3 doses, you do not see a difference in the sodium level from baseline to 1 hour, for example, after resuscitation. But based on this work, and this is again unpublished data, we designed out the first trial to compare epinephrine with vasopressin in our delivery room. Primary outcome, as we've done previously with the SURVIVE trials, was the time to ROSC, defined as heart rate greater than 60, sustained for 60 seconds. And you can see here several other of the secondary outcomes. And again, this was a cluster trial where we did 1 year of epinephrine and 1 year of vasopressin. And the only thing which changed in this cluster trial was the drug which was given during resuscitation. Now, chest compression is already rare. In our hospital, we maybe do 10 cases with chest compression a year. And you can see here that we did 1 year of epinephrine and 1 year of vasopressin, and you can see that the numbers are extremely small, where in addition to chest compression, they also received vasopressors. And so we are on extreme low numbers, 3 and 5, which are roughly similar to our previous pilot trial where we tried CC+SI versus 3-to-1, where we had 5 and 4. Now, the time to ROSC was 915 seconds with vasopressin, while it was only 333 seconds with epinephrine. As you saw in the slide before, there were only 3 cases, so the vasopressin group had just a minimal amount of patients to provide a statistical analysis. Mortality was the same, around 33 to 40%. So overall, vasopressin was feasible, even though there's a lot of extra steps to remind the team that vasopressin is the drug we're using at the moment, but it is feasible. And certainly gives us information to work on the next step and potentially do a larger study on comparing epinephrine with vasopressin. But in the meantime, chest compression and epinephrine are the 2 things we continue to do. Chest compression with the 3:1 chest compression to ventilation ratio, using 90 compressions and 30 inflations. The 2-thumb encircling hand technique. 1/3 of the anterior posterior diameter is our depth, and we will use 100% oxygen doing CPR. If we need epinephrine, we're going to give it at a dose of 0.02 milligrams per kilo, IV or intraosseous. Repeat that every 3 to 5 minutes. We always flush it with 3 ml of normal saline. And we need more human data. And here are people I have worked with over the last 15 years to work on CC+SI as well as vasopressin, and nothing could have been done without them. I want to remind everyone once again, Sunday evening between 6 and 7 p.m. at the Omni Boston Hotel at the Seaport, we have a HILO trial, particular Survive trial investigator meeting if you're interested. And I say thank you for your attention. And if you want to connect in any other way, here's all the links for social media to be in touch with me. Thank you.